my, can you see my
Yes,
slides
sir. Your
now?
slides are visible, sir.
Yeah, great. So this was an abstract in ELCC, evaluation of prognostic significance of PDL1 expression after combined CTRT in stage 3. So previous couple of talks were about CTRT in stage 3 lung cancer. So building upon from there, now the presenters was Dr. Jan Wagner. This is from Germany, and the authors are listed here. Now, just to give the background for this abstract, so this is a corollary from Pacific study. Now, Pacific study we know is a landmark trial which showed that patients with locally advanced unresectable stage 3 non-small cell lung cancer. So CTRT was done, and followed by that durvalumab was used. So which is a PD-L1 inhibitor. So this was compared with placebo. Now, in the updated and the final results of this study, it was seen that effect was limited to patients with PD-L1 expression of more than 1%. Now, if the expression was less than 1%, no benefit was seen, and it was partly due to the fact that the outcome in the control arm was surprisingly favorable. So it was speculated that lack of PD-L1 expression confers a favorable outcome after CTRT, right? So this was the background to which now they wanted to address this question, that whether this prolonged OS in the control group, so not in the durvalumab arm, but in the control arm, which lacked PD-L1 expression, so whether it is reproducible. So they analyzed their own this OS in a group of 101 patients with stage 3 non-small cell lung cancer who were treated with CTRT. So they took the cue from the specific trial and did their own study. And PDL1 expression was evaluated retrospectively, and the outcome in the group of PDL1 less than 1% and PDL1 more than 1% was subsequently compared. Now, just to recollect what happened in the Pacific trial, so we will just spend few seconds on this. So stage 3, above 18 years, PS good, durvalumab for 2 weekly for 12 months versus placebo. And so it was given 1 to 42 days after post CTRT, and these responses and PFS and OS were studied. So the updated analysis, so at 24 months, we had seen 66% versus 55% patients were alive. Uh, Excellent results, so which have not been replicated so far by any other drug. Now, this durvalumab consolidation after CRT continues to demonstrate durable PFS and sustained OS benefit in this pre-planned exploratory update at 4 years. So median OS for durvalumab was 47 months, and in the placebo arm, it was 29 months. So 4-year OS 49%. So nearly half of the patients were alive at 4 years versus 36% on the placebo arm. Now, so when we compare the PDL1, this stratification here, in the original study, it was the stratification was more than 25% PDL1 status versus less than 25%. And also we have to note that nearly 37% of the randomized patients had unknown PDL1 status. So it was not studied in nearly more than 1/3 of the patients. So in the overall study group, the HR was in favor of durvalumab. And if we substratify according to more than 25 versus less than 25, again it was in favor of this durvalumab. Now there was a post hoc analysis where it was asked to substratify according to PDL1 more than 1% versus less than 1%. Now here it was seen that if the PDL1 population less than 1% was seen, the placebo arm was doing better here, right? Now for durvalumab in US and for our DCJ approval also, PDL1 status is not required, but the European agency is asking for whether the PDL1 is more than 1% versus less than 1%. So that difference is there. Now in this particular abstract, so they did their own study, and so if the PDL1 expression was not evaluated, so available samples were again evaluated for this, and also age, gender, histology, smoking status, performance status, albumin, CRP. Now this is another marker they are doing here, and PFS OS were studied. Now they showed that the expression of PDL1 is independent from gender and histology. Median OS for less than 1% was 27 months and more than 1% was 19 months. However, it was not significant. Then median PFS also 9 months versus 10 months. This was also not significant. So they found that CRP values were actually, having a significant impact on OS, with 27 months for low CRP and 17 months for high CRP. Maybe we can start looking at this marker for prognostication. But other clinical parameters did not impact the OS. So this was their outcome of 101 patients of stage 3 non-small cell. So they concluded that the assumption that the lack of PDL1 expression confers good outcome versus more than 1%. So they did not actually prove this. So it was not justified in their 101 patients, which was there in the, let's say, Pacific trial. Now I have jotted down few more studies and meta-analysis. So this is a prognostic value of PDL1. So here they studied CD8 plus tumor infiltrating lymphocyte density also. So this is again locally advanced non-small cell treated with CTRT. Now this was again retrospectively assessed these clinical characteristics, and 31 inoperable patients were there. And so they again studied PDL1 expression 0 versus more than 1, and CD8 plus density 40% less or 41 to 100%. Coming to the outcome. So these showed that PDL1 expression less than 1% was associated with improved OS and PFS, right? And a trend towards improved OS and local control with low CD8 plus density. So evaluation of tumor immunity in microenvironment appears to be an independent prognostic factor for this. And so they have further stratification of type 1 versus type 4. So where PDL1 negative and CD8 low were doing better, and PDL1 positive, CD8 low were doing the worst. So according to this, PDL1 and CD8 plus can be studied. Now this is a meta-analysis of 50 studies where clinico-pathological and prognostic significance of PDL1 is studied by ISC. Now they are showing that high PDL1 expression was significantly associated with poor OS, right? Now here cutoff is 5%. And PDL1 expression was associated with males, with smokers, with poor tumor differentiation, larger size, positive lymph node, and KRAS mutation, and EGFR wild type. Now this is another paper where again prognostic value was studied in stage 3 non-small cell lung cancer treated with chemoradiotherapy. This is about 117 patients, and so this 1% versus or 50%. So these were the cutoff used. So patients with PS0 and who receive more than 60 grays of radiation toward a significantly better OS. So they showed there was no difference, whether it was more than or less than 1% or more than or less than 50%. So this paper showed PDL1 value doesn't, is not a predictor. Now this is again a review of literature of many studies. Now 35 studies were taken here, and immunohistochemistry method was the most frequently method used for PDL1 assay. So again, the study evidence did not support an association with PDL1 expression in gender, age, smoking, tumor histology, PS, grade, EGFR. In several studies, high expression was associated with shorter survival. But they consistently found that the most of the studies showed that high versus low PDL1 expression were more likely to experience treatment benefit with the anti-PDL1 drugs, so which are nivolumab, pembro, durvalumab, atezo, and avelumab. And so there is a lot of variability in the methods used to determine PDL1 expression. So this is about my talk. I can stop sharing. So still there is no final answer to whether this PDL1 expression less than 1 or more than 1, less than 5, more than 5, less than 25 or less than 50, more than 50. So this is still to be answered. And again, the assays being used are there are too many. And so somebody is using DECO, Ventana SP142, Ventana SP263. So there is a lot of variability in the methods of testing this, and a lot of variability in the cutoffs. So the final answer is still not there. But Pacific being the largest trial for this and less than 1% versus more than 1% appears to be a good cutoff to my mind. So what I could gather from reading all this. So maybe we can stratify there whether to use durvalumab in stage 3 non-small cell lung cancer post-CTRT. Thank you.